Hello, everyone. We are continuing our coffee chat series. In the month of April, we've been talking about rosacea. We've been showing you some great before and afters of laser treatments. We've been talking about novel topical therapies that we've been incorporating in the practice, like BioJuve. So if you have questions about this and more interest, let us know. We're happy to directly contact you. And we are finishing this Rosacea Awareness Month with a very interesting conversation. As I discuss with patients in clinical rooms, we talk about the GI connection to rosacea as we talk about the GI connection with other skin disorders. So I am so privileged to welcome Dr. Preston Stewart, who is my new neighbor in the building on the Howell Mill. Dr. Stewart has been in practice for many years. He'll tell you all about himself in just a moment, but just recently in the last few months moved practice to the building that we've been in for several years. So I think that's so exciting and welcome, and I'm so glad that you can spend a little bit of time with me.
Well, thank you very much for having me, and I'm very excited about joining you for a chat today.
Wonderful,
thank you very much.
So tell our viewers a little bit about yourself, your training, how long you've been in the practice.
So originally from Atlanta, and I have been in private practice for 20 years now, and with Digestive Healthcare of Georgia, which is my group. When, as you said, we've just moved over here to our new location, and we're loving it. I trained, I went to med school at Emory University, and then I did my training in internal medicine or residency at Vanderbilt University, and then followed up in GI fellowship at Vanderbilt University as well.
So, wonderful. So great, strong Atlanta roots, and we both are Emoroids.
Yes, that's right.
That is my alma mater as well, so fantastic.
Yeah.
We as dermatologists certainly actually talk about the gut and the gut-skin axis when we see patients quite frequently, particularly with disorders like rosacea, that very commonly is affected by the diet. So since this is Rosacea Awareness Month, I thought we'd start with that. And I would like to hear your thoughts about the gut-skin axis and what do you, from your standpoint, tell patients?
Sure, absolutely. So the skin-gut axis is a fascinating and very complex relationship between it's a two-way relationship actually between what is called the microbiome of the gut and the skin. And the microbiome is a collection of organisms, bacteria, fungi, viruses actually, that largely are based in the colon, and there are trillions of them. The numbers are astonishing, and there are, of course, numerous organisms on the skin as well. And they communicate via our immune system, which is our defense network. And it's a very complex kind of lines of communication, and has opened up multiple areas of research that are just emerging now. And so that interplay between immune system, skin, and gut really drives a lot of what we call homeostasis in our body, or the kind of the balance of our body systems and our health. And when that goes awry, we see consequences, which in our gut are inflammatory bowel diseases, many others, as well as skin diseases like rosacea and atopic dermatitis, I believe, and some of these others. So there's a direct interplay between the two.
And we talk about the microbiome quite a bit from the cutaneous standpoint. We've learned quite a bit, and I've mentioned briefly in the opening remarks about one of the newer topicals that we're using that very specifically affects the microbiome, and we describe it as the probiotic-like for the skin.
Right.
Do you get into conversations with patients about probiotics and postbiotics, and maybe a quick comment? How do they differ? What's the difference?
Yeah, it again is a new and emerging area of medicine as a whole, but certainly in GI. And we know that a condition called dysbiosis is where the microbiome, in a sense, goes awry. The community of these organisms are altered in some fashion, and that can occur by antibiotics, can occur by immunodeficiencies, and so forth. And so when dysbiosis occurs, there are multiple disease states and disorders that can occur. And one of the weapons against this is trying to supply back the good bacteria, which we call probiotics. Now, there are numerous formulations on the market, and it can be quite complex to navigate, which it is. I have a few that I are comfortable with and have gone to, and I feel like have been effective. It is sometimes guesswork as to which one would be the right fit. And we usually know that there are a few classic healthy bacteria, lactobacilli, bifido, and these are found in a lot of these formulations. And if we can repopulate in the gut, then we think that we can rebalance the microbiome, and hence we can then obviously help with some of these disorders. There's the concept of prebiotic and postbiotic gets a little bit more nebulous, and I struggle with it some.
I'm with you on that one, actually.
And prebiotics, essentially, the way I define it, are just kind of the fuel for the probiotics, or are essentially fiber, things of healthy nutrition. Of course, there are many, expensive formulations out on the market, so you have to be wary of that a bit. But in terms of postbiotics, that's a little bit more, even more nebulous. And I'll be honest with you, I don't routinely pursue that in my practice.
And I love hearing that, because it's a concept that pops up, in a little bit more literature, and I think it's important to address that. I mean, and I think that's the benefit of coming to see a specialist, when you really talk about things that are science-based and so important. Going back to rosacea, because I do think you mentioned diet, one of the things that we have for years talked about is also putting patients on H2 blockers that suffer with rosacea. Do you have these conversations in the clinic, and can you give a little bit of a twist on your explanation why those work?
So from, I guess, the H2RAs, or the histamine blockers, are famotidine or Pepcid, or Zantac, which is now famotidine. The other one was taken off. But we have these available. We use them in GI quite frequently as acid blockers in the stomach. And that has the immediate effect of treating diseases or disorders like reflux disease or GERD. It helps heal maybe ulcers. We have more powerful medicines. But in terms of its effect on the skin, it's actually surprising that you use them. And I'll be honest with you, I'm not, the mechanism I suspect might be that when we block acid, that it perhaps alters the microbiome in a sense. Because
and I think that's probably the origin of the thinking. There are some articles, reports that have shown that increasing H. pylori does have a direct correlation with flaring rosacea.
Yeah, it's fascinating.
Which, it's really fascinating. So one of the lesser known facts is that, I have been a dermatologist for 30 years, but my beginnings really were I was very seriously looking at GI. So maybe that's why I love the connection. And the connection doesn't stop at rosacea. There are a number of other skin presentations of GI disorders that we see in the clinic. So are there a few that you could mention that you'll go, oh gosh, well, gotta send them to dermatology consultants?
Yeah, and one kind of opens up a big topic that I think is very important for us in gastroenterology, and where we collaborate frequently with dermatology specialists, is in the realm of inflammatory bowel diseases, and that would be Crohn's disease and ulcerative colitis primarily. And one of the most common extraintestinal manifestations, or manifestations of the disorder of the gut that we see, are skin manifestations of these diseases. And there are a few that we see, like erythema nodosum and pyoderma gangrenosum. These are technical terms, but they can be very disabling skin diseases. Some parallel the disease activity inside the intestine, the inflammation, some do not. But they typically require a collaborative effort between a gastroenterologist and a dermatologist, because they require powerful medications to get them in control. But that is a direct result of the immune intolerance that occurs with inflammatory bowel disease, where the immune system targets parts of our body, the intestine, the skin,
Right.
thinking that it's enemy because it's miscommunicating with our microbiome. And it's more complex than that, but simply that's what happens. And so
I think that's such an interesting collaboration. So even outside of academic medicine, we certainly collaborate, and we do have a number of general dermatologists that work with GI groups that really can put together the newest medications, whether these are appropriately chosen biologicals or other
Right.
medications that really can
Correct.
improve the quality of life for the patient.
absolutely,
Yeah.
absolutely.
I think that the connection of the gut-skin axis is not well appreciated many times. So I'm
Right.
glad we're talking about this.
Absolutely.
I do think that I like to send patients or our viewers, everybody in my world almost is a patient,
Yeah.
but with a message that's important, and I think that it's a great time to also highlight colonoscopy and what is the frequency and what are the current recommendations. I really don't want to leave without
Right.
talking a little bit about that.
Extremely important topic, and especially with emerging reports of younger men and women who are developing colorectal cancer. So screening and preventative care are essential in our line of work and in all of our line of works. But colonoscopy specifically is a powerful tool at reducing the incidence and the mortality or the death rate from colorectal cancer. And the typical age to start screening in an average risk person is 45 now. That was recently moved up by our major societies, including the U.S. Multi-Specialty Task Force, because recognizing these earlier onset cases there. And I think that's been instrumental.
Is that true for both men and women?
Absolutely. So on all ethnicities and so forth. Now, that's the average risk population. If there is a higher risk population, that would be somebody with a family history, primary family members, first degree relatives, as we call them, with colorectal cancer or
Right.
an advanced precancerous polyp. Then we would typically recalculate the age of that individual, that first degree relative, and it might be that we start much earlier, sometimes 10 years earlier than the age of that first degree relative at the
Right.
time of their diagnosis. So we always want to individualize our screening protocols,
Absolutely.
but in general, 45 is now.
And then how frequently for the repetition of the screening?
So the good news is the preparation is the hard part that
It's
gets the
gotten
bad
better.
rap.
It's gotten
a
better.
little bit
It's
better.
gotten better.
It's not as bad as I like to say. So, but that might dissuade some people, but it's getting better. So the good news is that if average risk person has a colonoscopy and no polyps are found, one can go 10 years before they have to go through the process again. So, but if we do find what are called polyps, and that's what we're really screening for, are these
yes.
little growths along the lining of the colon and rectum that can be precancerous. We remove them right then and there. If they are more than 3, or they're larger, or under the microscope they might have more advanced changes, then we might have that person come back in 3 years, or sometimes 5. But 1, 2 polyps will definitely bring them back in 5 typically. So.
Well, what an important message, I think so. Those parameters have changed. 45 is very young,
It is. It's a
but
big
I think
step forward.
what an important tool to identify. So I would encourage everyone to really keep that in mind, that is really one of those screenings. We'll be talking about our screenings in May because that's the Skin Cancer Awareness Month when we encourage everybody to come once a year. But when it comes to the gut, I think that is so important, and we have such great tools that we don't want our patients underutilize those.
Absolutely.
Well, thank you so much.
Well,
This is, I learn every time I sit down with our guests, so I'm so appreciative
Well,
for your time.
Again, grateful
And,
for you having me.
Welcome to
today.
the
So,
neighborhood, and
thank
let's
you.
continue that
Absolutely.
gut-skin axis collaboration. Thank you
Without
so much.
question. Thank you.